A very warm good morning to all of you from India. I'm truly honored to be with all of you here today and really thank the Ukrainian Society for having me on board in this wonderful academic conference. So, with the COVID-19 pandemic, we began seeing stories about love during the lockdown and advice on how to date at a distance. And while this seemed surprising to most of us, never did we realize that soon this would become the new normal. And humans are a progressive race, and procreation is essential for survival. So it is important to know what are the implications of COVID-19 and this global pandemic on sexual health overall. And your patients may ask you if they can pull a Kim Kardashian, that there are various questions you need to answer. For the obstetrician, there may be questions relating to pregnancy or fertility, while in men, relating to infertility due to orchitis and thrombosis are the prime concerns apart from sexual transmission. And if you view it from the lens of the immunologist, then there are other challenges and problems to look into, which include thrombosis, what happens in severe COVID hyperinflammation, autoimmunity after COVID, and the damage left behind and how to deal with it. And there are emerging concerns regarding COVID-19 and gender. It is definitely known to affect men way more than women. And there may be an interplay between hormones, a gene dose effect, and even thrombosis is more likely to be severe in men. And this carries important implications for treatment and the use of hormone therapy in this disease, which is otherwise very challenging to treat. So why is pregnancy a concern? It is a relatively immunocompromised state, and there can be altered pulmonary function, which can again put them at an additional risk. It is also a hypercoagulable state, which is likely to worsen with the presence of COVID. So some respite here that the COVID-19 is less vicious in terms of mortality when we compare it with MERS and SARS in pregnancy. Previous viruses had mortality to the tune of 18 to 25%, while with COVID, that is much lower. And this may explain the relative affliction for men and more severe disease. So there is an interplay between hormones and possibly the XX and XY chromosome, as we will see in a bit. And even the other fetal complications seem to be much lower in COVID-19 compared to the previous coronaviruses, with the exception of preterm births, which have been reported in small studies. So, with the onset of the pandemic, there was a flood of information, and it was difficult to deal with misinformation, due to which we saw various infographics. Is one example from Penn Medicine in the United States, where which suggested that 10,000 pregnant women have been diagnosed with COVID-19, but only 57 have needed a ventilator. So the evidence is still emerging in this area, but this is what we have as of now. Some small studies, level 3 evidence, weak level, as you can see, have suggested preterm deliveries. Some say they're no different, which have a better level of evidence. And again, most of them say there is no difference in maternal status in the prenatal and postpartum period. But infants can sometimes be positive. So this is another thing which is concerning. And we now know for sure that COVID-19 has a lower case fatality rate than previous coronaviruses. And pregnant patients have similar signs and symptoms, but susceptibility in pregnancy is not increased. And preterm delivery may occur in severe disease, but adverse outcomes, when they occur, their relation with COVID-19 is not very clear. But the questions which still boggle an immunologist's mind are the risk of thrombosis and COVID hyperinflammation and the damage thereafter. And there is some emerging evidence to support that there is indeed some placental villitis and malperfusion in COVID-19, despite the good clinical outcomes. Otherwise, there is chronic villitis, macrophages and CD8 plus T cells. There is thrombosis, and surprisingly, these even affect those cases who are mild or have been asymptomatic and were detected merely by screening for the virus. And another series which reports that placental pathology includes thrombosis and fibrin deposits in stem vessels, the most common lesion, which may translate into poorer perfusion. And the effects on the fetus in long term are not very clear as of now. So COVID-19 associated coagulopathy is in fact now a well-defined syndrome, and it is being increasingly described in individuals with severe COVID-19 and hospitalized cases, as in this report recently published in Science Translational Med, where 8 types of APLs were measured, including IgM and IgA, to the 3 classic antiphospholipids. And these were detected in the range of 24 to 18 to 24%, ranging from IgG, phosphatidylserine, to IgM, anticardiolipin. And overall, nearly half of the patients had some antibodies, and 30% even after using a very stringent cutoff. Now, it is important to know that these patients have APLs, but these are also pathogenic. So the patients who had higher antibody levels had higher neutrophil extracellular traps, and they also had more severe COVID-19. And when sera from these patients were immunized, mice were immunized with sera from these patients, then these could induce thrombosis. So this is a very important finding which suggests that COVID-19 is a prothrombotic state, and the APLs could predict severe thrombosis, and something to look out for, almost akin to that seen in CAPS, which can be a fatal condition. So there's much we need to know about this condition, and also whether these mechanisms are operative in the placenta and to what extent. In fact, a recent paper has also shown complement deposits similar to what we see in antiphospholipid syndrome. So this has led to preliminary guidelines, because pregnancy is a procoagulant state per se, and the interpretation of tests in the presence of COVID can be very difficult. So for PT and APTT, it's better to take a cutoff, the ratios rather than the times measured in seconds. Platelet count, the cutoff remains the same, but for D-dimer, one needs to be wary of overdiagnosing COVID coagulopathy, because it can be elevated even in normal pregnancy, 2 milligram per deciliters or so. So several fold above the upper normal for your laboratory would be the ideal cutoff, while FTPs are to be viewed with greater suspicion, and any FTP elevation should be taken as an early pathologic sign. And for DIC, established scoring systems should be used. While for fibrinogen, levels are elevated in pregnancy, so it's not very clear as of now, and more studies are needed before we can describe cutoff. So the question which naturally comes to an immunologist's mind is, there are APLs, and these women, if they get pregnant, does this translate into a higher risk for miscarriages in early pregnancy, even in the asymptomatic women, just like the antiphospholipid syndrome? Unfortunately, there's not much data yet. There have been 2 studies recently which have come up, and the sample size was nominal, and does not suggest as of now, but something we need to look out for in the future. Another dilemma which comes up in the 3rd trimester, if COVID-19 affects individuals, then what are the implications for the preterm neonate? And accelerated lung maturity may be something which we would like to have, and it may be time for antenatal steroids, but it does pose some risk to the mother, which needs to be substantiated by further studies. So as you can see here, and all of us would agree that COVID-19 is now a total enigma, and who gets COVID-19? Pretty much everyone, but then there are some exceptions to the rule. So definitely there is a subgroup of individuals who may be predisposed to more severe disease, as seen in recent papers published in top journals, where polymorphisms of the toll-like receptor 7, which is important in antiviral response, and interferon pathway defects can predispose even young individuals to severe COVID-19. And even antibodies to type 1 interferon, which are sometimes present in lupus patients, has been shown to predispose to severe COVID-19. Now, since a lot of these genes lie on the X chromosome, it puts men at an additional risk due to this disease. And clearly, there's a genetic predisposition which is being understood over time. But what happens after you get COVID-19? A lot of autoantibodies are present. In fact, nearly half of the patients test positive for at least one antibody. 1/3 of these can be ANAs. and 25 to 50% are APL, depending on the test conducted. And anchor reactivity has been detected in some studies and not in some others. So the question which comes to our mind is COVID-19 and autoimmune disease. Uh, a very interesting question when asked to a rheumatologist, but unfortunately the answer is not very clear. It just seemed to be yes, but we need more data to support that before we can say that. But the other thing which is very clear as of now is COVID-19 is definitely bringing us to the crossroad between infection, immunodeficiency, and autoimmunity, and a very important crossroad where the crosstalk between different pathways may determine the ultimate outcome. Much needs to be understood about this enigmatic disease, as we can see here. The other major question which is coming up is the effect on fertility. And as humans are a progressive race and procreation is very important, this is something of concern to all of us. Now, the early pandemic period in Milan and Italy and in the surrounding areas, it resulted in an automatic shutdown of assisted reproduction clinics. And this is very important because of the high rates of infertility in some of these countries, particularly in the developed world, where a lot of young population seeks assisted reproductive care. And as you can see, there were voluntary shut off or government imposed guidelines, and then other forced by the local guidelines. And there were various questions that came up in this period, whether this can be sexually transmitted. So this raised the bar for screening for cryopreservation. In fact, it has long-lasting implications because some of these can cryopreserve for years. And this is a question which unfortunately has not been answered clearly till date. And of course, there are bioethical dilemmas if the sperm count is low, or if the sperms are not very efficient, or if there is a biohazard in the specimen. But then there are patient rights to reproduction, which you cannot deny them of. And the economic repercussions also could have important effects on the ability to reproduce. Some people shifted to Zoom calls and teleconsultations, but the fatigue and the other problems with this approach are also something which needs to be better understood to deliver better care. Now, as we would expect, the emotional reactions of patients to fertility clinic closures have been immense. There's a lot of nervousness, sadness, feelings of discouragement, which have translated into a negative mental health impact. As we can see here, a lot of negative impact and very little positive, hardly any, as we would expect. Uh, One thing which seems certain as of now is the effect on infertility is way more profound on males than in women. And there can be several factors influencing this dynamic, um, including the appearance of fever, which itself can inhibit spermatogenesis, or the virus itself on Sertoli cells. Now, the dual attachment of the virus is very important in infecting any particular cell. And unfortunately, the male reproductive tract seems to have high levels of both AC2 and TMPRSS2. This is the key enzyme or the protease, which is important in cleaving the spike protein and facilitating the entry of virus into the cells. Now, this dual attachment may be possible in the male reproductive tract, which is really raising concerns regarding sexual transmission and long-term effects of hypogonadism in these individuals. Now, this can be a vicious cycle. Once it affects the Sertoli cells and Leydig cells, there'll be decreased production of testosterone, which can accentuate hypogonadism. And then there are preliminary reports of orchitis and thrombosis. Now, the testis has a very limited blood supply and a very compartmentalized distribution of blood vessels, and any kind of thrombosis in this area can be really detrimental to the health of the sperms. So autoimmune orchitis, there's emerging evidence to support that in a group of individuals here. As you can see, the number of apoptotic cells was higher in individuals with COVID-19. And the semen analysis revealed that nearly 39% had oligospermia and 60% showed an increase in leukocytes. So there was increase in immune infiltration in different parts of the um, male reproductive system. And the cytokines in semen, not in serum, in semen were also much higher than the age matched controls. So clearly supports a role of ongoing inflammation. Whether the virus is present itself is not as much clear as of now, but it can be a vicious cycle, as we discussed earlier, with feeding itself with further hypogonadism once the inciting insult is gone. So this has massive implications for assisted reproductive techniques and sperm banking, given that 80% of infections with SARS-CoV are asymptomatic. And it is also very difficult to ascertain if a person has had infection because the autoantibodies to COVID-19 are short-lasting. Fortunately, one good thing is that the female reproductive tract has low concentrations of SARS-CoV-2 receptors. So that is some respite indeed, and it seems unlikely that the female reproductive tract would be influenced to that extent. Although there are reports of ovarian vein thrombosis after COVID-19 in a pregnancy, and thrombosis just like at other sites as well, like cavernous sinus and pulmonary thrombosis. So the ovary is no exception, and there may be rare instances, but this seems to be occasional at best. Now, I would like to introduce you to this very interesting concept, which is published recently in Science, which said that birth trends in response to the pandemic may significantly vary according to socioeconomic conditions. Now, in high-income countries, the long-term impact can be decreased access to ART and decreased fertility, which will result in shrinking population sizes in the long term. While in low-income countries, it will result in decreased access to contraception and increased economic losses and uncertainty, which can translate into an increased birth rate. And the population size may increase and aging may decrease, which will again shift the population dynamic entirely. So, some things are for sure that it can affect human fertility. There is a reasonable chance of that happening, although the risk is much higher for men than women. Although the evidence backing underlying pathology is still in nascent stages, we need to understand more about what is happening there, and thrombosis and orchitis may be the prime players for all we know as of now. Um, Economic and logistic issues really add to the challenge of fertility, and this may have an outsized impact on the population distribution in subsequent years. In fact, this will affect the rate of population aging, shape future health challenges, and economic growth potential across the globe. Now, we seem to have covered a reasonable bit the concerns to the obstetrician and the key concerns to the immunologist, but what remains to be answered is why does COVID-19 affect men disproportionately and lead to more severe disease, as is known, across the different age groups and across countries? So this is something we need to dig deeper into, and probably some of the answers may lie in the immune origins of the COVID-19 inflammation. So as we said that ACE2 receptor and proteases are important for virus entry into the cell, and ACE2 receptors are underexpressed in the presence of estrogen. There are studies on bronchial epithelial cells conducted where the estrogen levels akin to pregnancy led to a decreased expression of ACE2 receptors. So this may explain why the virus cannot really enter cells and lead to severe mortality and huge effects on disease severity in pregnant women. The other most important thing here is that the viral sensing response, a lot of these genes and molecules which are important, these genes lie on the X chromosome. One particular player is the TLR7, and a recent report published in JAMA suggested that young men who had severe disease, it described 4 men having a rare polymorphism who had very severe disease and required ventilatory support, actually had mutation in this gene. And since they were men, they had only one copy of the gene, which was knocked out, as compared with women who are likely to be asymptomatic for the condition. And later, another paper in Science described numerous such defects in young individuals to the tune of 15 to 20% of young individuals who have severe COVID-19 have immune pathway defects in one of these interferon response genes. And a lot of these lie on the X chromosome. So COVID-19 has led us into the discovery of new primary immunodeficiencies, but it has also opened the pathway for newer therapeutics, because now we understand that an interplay between hormones and genes may be very important for the pathogenesis of this condition. And as a result, there are various ongoing trials of hormone therapy. We don't know how much hope to keep, but definitely this is something from the immunologist lens, which does seem interesting and to watch out for in the times to come. The other gray areas which still remain unsorted are sexual transmission. There is some evidence of the presence of SARS-CoV-2 in seminal fluid, but the answer, I would say, still remains elusive. As you can see here, the various studies conducted, most of them did not demonstrate the presence of the virus in sperms, in semen, although one study which has been criticized for some methodology flaws, including absence of reported data on the technique for testing for the virus, the cutoffs of RT-PCR. It was presumed that it was RT-PCR, and 6%, 6 men tested positive. The collection technique was again not very clear, so raising concerns about the methods and validity of these results. It's something which needs to be studied further, because it can have major impact on transmission at the population level. While until then, it is advisable to slow courtship and stay safe. But another concern is vertical transmission in the fetus. Again, this seems to be okay. Most reports suggest there's no viral RNA in the amniotic fluid, cord blood, or breast milk, but one single report in JAMA suggests that vertical transmission may be possible. And so there are unsorted issues like sexual and vertical transmission, universal testing. So in the hospitals, at the ground reality is you test everyone for COVID-19 and then they test negative, but RT-PCR can have a 30% false negative. And it can lead to the presumption that all of these individuals are COVID negative. And the absence, the healthcare workers may not use PPE, and leading to mini outbreaks, which may be very frequent. And then guidance on the assessment of coagulopathy. There are some guidelines, but they're very preliminary, and we need more data to understand how to classify COVID coagulopathy. And autoimmunity after COVID-19 is a very emerging and interesting area, which we need to know more about to understand the long-term impact of this disease. So the take-home message for today is that pregnancy in COVID-19 is less severe. Hypogonadism is a real risk, more so in men, although the risk of sexual transmission is still unclear. And COVID-19 and autoimmunity is a very real phenomena, and urgent studies are needed to understand the long-term impact. Unfortunately, most of the data until now is still observational, undersized, and reports heterogeneous outcomes. And weak evidence may in fact jeopardize recommendations. So there's an urgent need to conduct research to clarify these outcomes on a global level. Until then, it is advisable to stay safe. Thank you very much. As I sit here, this is the view from my outpatient clinic. And once this pandemic is behind us, I invite all of you to come join me and enjoy the view. Thank you.